Hello, good evening, everybody, and welcome to this evening's Facebook Live. My name is Alec. I'm the MD of Wound Care People, for those of you that don't know yet. This evening's session is in partnership with L&R, and it is part 2 of the Leg Ulcer series. And tonight's session is Interim Care, progressing towards self-care. So this is, as I said, part of a 3-part series. So but don't worry too much if you didn't catch up with us on the on part 1, which is on the 13th of July over on our GPN sister page, which was immediate care to prevention of recurrence. You can watch it at any time via the GPN website or via the GPN Facebook page. Tonight's speaker is yet again none other than the amazing Dr. Leanne Atkin, who's a lecturer practitioner over at University of Huddersfield, and she's a vascular nurse consultant with Mid York's NHS Trust. Leanne, are you there?
Good evening.
Good evening. Welcome. We were just saying that the first one of these was 13th of July, and because it feels like as though we've actually had a decent summer this year, it feels like quite a while since the last one, doesn't it?
It does, but at the same time, I feel like Mother Nature's got a hand on the speed dial, because by heck is this year going fast.
Yeah, absolutely. Christmas before we know it, but we won't talk about that. So listen, so as always, you can see that we're presenting from our homes. If there are any technical issues, do please bear with us. Certificates for your CPD will be available at the end of the presentation. One of my colleagues who's going to be answering your questions in the comments section tonight, I'll put a link up there so you can download the certificate at the end of the event. So do as I said, do bear with us if we have any technical issues. I would just like to thank L&R for not just supporting these 3 events. As I said, they're 3 fantastic events, but also this weekend we've had the wonderful Pride event in Cardiff, which they've supported. We've had nurses from all over the UK, along with representatives of a number of different companies, including L&R, who have been supporting lower limb health throughout the Pride event. So thank you very much to the whole team there at L&R for supporting that. Leanne, I'm going to hand over to you now, because I think that's about it for the housekeeping element. I will just make one quick apology, and that is if you can hear any noise in the background, that's my new dog. So I do apologize. He's never been with me on a Facebook Live before, so this is he needs to learn how to be quiet and behave. So I'll hand over to you. I'll be back for the live Q&A. As always, sorry, there is one more thing. Please do ask as many questions as you possibly can throughout the event. I know that we've already got some questions coming in. Let us know where you're from. Let us know what type of nurse you are and where you work. We're always interested to know that. And I'll be back after the presentation to chat with Leanne to go through the live Q&A. Leanne, good luck. I'll see you shortly.
So thanks, Alec, for that introduction. So today's session, as Alec has said, is building on part 1, and this is part 2. So hopefully by the end of today, your learning objectives for this session is to really understand the current recommendations of best practice in terms of how do you treat a patient with a venous leg ulcer. And it's not just talking about those self-care solutions, but actually talking about the necessary care for that patient. I also, by the end of this, want you to have the knowledge and a little bit more confidence in the ability to be able to implement these practical solutions so you can progress your patient through this wound healing to where self-care becomes appropriate. So just a little recap really for those of you that missed the last session, even if you came to the first session. I always find actually presenting these statistics really helps to bring home the true burden of leg ulceration across the UK. We cannot forget that annually across the NHS, we spend £3.1 billion each and every year helping these patients to manage with their venous leg ulceration. Leg ulceration is extremely common. Around 1 million patients across the UK are affected. That equates to around 2% of the adult population. If you look at the prevalence that comes out along with that prevalence, the management of these patients take up a significant amount of nursing time. Up to 50% of community nurses' time is taken up on management of patients with lower limb wounds. And I suppose of all of these statistics on this slide, the worst one for me is the fact that we have recurrence rates of up to 69%. So in other words, if you helped a patient to heal with a venous leg ulcer within the next 12 months after that healing has occurred, At the moment across the UK, there's around a 69% chance it's going to recur within that next 12 months. There's no reason why that figure is so high, other than inappropriate care and the patients are not understanding the need for long-term compression. So all of these things, I think that actually we have an opportunity. We have an opportunity to reduce the amount of cost, to reduce the amount of patients who's actively got a leg ulcer, to reduce that risk of recurrence, and actually reduce the time that you're spending caring for these patients with these venous leg ulceration. And I do think something must change to reduce all of this, because the NHS certainly isn't getting the investment of resources or staffing that one could think that we need. I do think, though, we're not truly getting this right across the UK at this moment in time, and I'm not the only person that's saying this. I was very fortunate to be part of the National Wound Care Strategy Programme when we were writing the lower limb clinical recommendations. If you haven't read this document, I urge you to download this document, read this document, and this really is the Bible of how you should be treating a patient with a lower limb wound. I'm sure a link to that document will be posted on the screen by the fantastic people behind me. But the National Wound Care Strategy thinks that this unwarranted variation of clinical practice, in other words, that we're all doing slightly different things, gives us an opportunity. It gives us a major opportunity to improve healing rates, to reduce patient suffering, to reduce that spend on ineffective and inappropriate treatments, and to reduce the amount of clinical time you are spending caring for these patients. This document really is embedded within the evidence base, and it talks about really three distinct phases: the immediate and necessary care, the diagnosis and treatment, and the need for ongoing maintenance. So on the first session that we did a few months back, we concentrated on that part one, if you like, that immediate and necessary care. I don't want to dwell on this so much, but I think it's really important that each and every one of you has the ability to recognise the red flags. In other words, where is your patients have got these red flags? Where do they need urgent escalation? Where do they need that immediate care? And actually, if you're able to assess competently that a patient hasn't got any red flags, you are now allowed to use up to 20 millimetres of mercury compression without any form of formal vascular assessment. No ABPI, no toe pressure, no pulse palpation. Red flag assessment, no red flags. It's safe to apply maximum of 20 millimetres of mercury compression. It really recaps and really reinforces the timeline to assessment. You should assess a patient holistically with a lower limb wound as soon as possible. You've got a maximum time frame of 14 days. The more delay, the more harm that we can do to those patients. And it really talks this first session about how important that early prevention is in terms of how actually can we prevent these patients from developing venous leg ulceration. So please do catch up on that session. But today's session is really going to focus on the best practice for the treatment of a patient with a venous leg ulcer. And myself and Joy Tickle back in 2016 wrote this lower limb pathway, and I can't believe how successful this has been. I find it really useful because it's a one-page algorithm. Follow these boxes, these questions, you will deliver good, high-quality, evidence-based care. And actually, if you look at the recommendations that's come out of the National Wound Care Strategy, it's all very much focused in line with our pathway that me and Joy created. We'll be focusing really about this embracing self-care and what that can do to your patients, but what that can do as a healthcare professional in part 3 of this series. So put a date in your diary for Tuesday, the October the 11th, and me and Alec will be back then. So I think the one thing that I'd like you to take home from the end of this session is if you have a patient with a venous leg ulcer, the one thing that you need to do is to apply strong compression on that patient. It's absolutely evidence-based. There are meta-analysis, randomized control trials, systematic reviews to say that the best thing to do with these patients is apply strong compression. And when we talk about strong compression, it's of at least 40 milligrams of mercury pressure. There's a myth out there that to say, that if we applied reduced compression, light compression, modified compression, it's therapeutic for a patient with a venous leg ulcer. Unfortunately, it's not. The dose that's required to treat that underlying venous hypertension, that underlying venous inflammation, the reason why that wound is there, the therapeutic dose is 40 millimeters of mercury. It's the same dosing if you think about how you'd therapeutically dose somebody for some antibiotics or some analgesia. There's no point in giving half a dose. It's not therapeutic. Obviously, before you apply any form of strong compression, you would ensure that your patient's got a full holistic assessment, including an assessment of their arterial supply. But we're taking it that if you've got no issues with arterial disease and your patient's been diagnosed with a venous leg ulcer, the thing that you need is that strong compression. Some of you out there might be thinking, okay, yeah, this is nothing new to me, Leanne. But actually, I must tell you that the majority of patients out there throughout the UK do not get full strength compression. There's a huge elephant in the room that we're not talking about this, and that's why I'm delighted to be here in partnership with Eleanor and JCN to be able to talk about the importance of this. Unfortunately, the number of reduced compressions are increasing, are being sold, and we need to ensure that our patients have got that full therapeutic compression. And it's about how we sell this to our patients. We should be, as a clinical workforce, positively promoting the use of strong compression. And we should be doing that by talking about education with our patients and the language that we use. Don't talk about tight bandages. Tight bandages got a negative connotation. Talk about them with your patients, about squeezing the veins and squeezing that venous hypertension, getting rid of that chronic inflammation. Many of you might think that reduced compression is better for the patient because it's not as painful. You've got to think about why the pain is there. The pain is there because of the amount of inflammatory mediators that's in that tissue at that time. Therefore, the best way to reduce that patient's pain is to reduce those inflammatory mediators. And the best way to do that is that strong compression. We may require some analgesia initially or some distraction techniques. But if your patient's got a pain, the best thing you can do is to get them onto strong therapeutic compression. And within 14 days, their pain will start to reduce. I also think that we need to change our mindset in terms of we sometimes have a fear of doing harm. We have a fear of not applying strong compression because of the litigation, the fact that this may cause ischemia. There is the same harm that happens though from apathy. There is a huge harm by no compression, not the appropriate dose of compression. That wet leg, that elongated patient suffering is all a symptom of us not dosing the compression correctly. We need you to have the confidence to be able to think about the requirement of that compression. And hopefully this session will help to build your confidence. I've been talking a lot about self-supported solutions for a long time. I think that it's really useful for patients wherever possible to be in a compression hosiery kit or to be in a compression wrap system. Because actually, if they're able to maintain their own wound care, to bath and shower as they want, they actually get less reliant on the healthcare system and the more empowerfulness of their health behaviours and their healthy choices within their life, and how that makes a difference to their overall well-being. For the patients, though, it's important that we use compression bandaging where needed. For patients that are suitable for compression hosiery kits or for compression wrap systems, there's two things that we simply need to assess. Number one, is the exudate controlled within the dressing? If the exudate is controlled within a dressing, you can put that hosiery kit on top of it with no issue. And the next thing to really ask yourself is the minimal amount of edema or minimal amount of limb distortion. Because if there is significant amount of edema, self-supported solutions such as hosiery kits or compression wraps are not the best option at this moment in time. So we need to think about, have you got a leg that looks like that, beautifully and thin, looks like that exudate is quite low, looks like the dressing is going to be able to control that exudate. That patient looks ideal to me for a compression hosiery kit. The next patient, that limb is quite large, but he's quite an obese gentleman. There's not much limb distortion there. He's got a normal shaped leg. The exudate can be controlled within a dressing so long as you use a large enough dressing. And again, that patient looks suitable for compression hosiery kit, but that patient couldn't touch his toes because of his obesity, and therefore that patient were ideal for a compression wrap system. We need to be thinking about self-supported solutions, not just of what the patient can apply, but actually both the compression hosiery kit and the compression wrap system makes life a lot easier for us as a healthcare professional. Any of these kits and systems can be applied by any healthcare professional, whether they're registered or unregistered, with a minimal amount of education and training. But some of your patients may not be suitable for those types of self-supported solutions as yet, in terms of those wraps or those hosiery kits. And within the compression algorithm that myself and Joy wrote, it's quite clear of where you need to use a compression bandage. These are two clinical examples of where compression bandaging is required and compression hosiery kits or compression wrap systems are not appropriate. That first patient, you can see the high volumes of exudate that's going to be coming from that venous leg ulcer. You can see the positioning of that leg ulcer. It's going to be very difficult to get this dressings all the way around to be able to get them with a good seal to be able to stop that exudate macerating on that surrounding system. That patient needs healthcare, they need a healthcare professional. The next patient, you can see the limb distortion, you can see the lumps and the bumps of the soft edema. That patient needs good compression bandaging to help restore that normal limb profile, to get rid of some of that soft edema as quickly as possible. And both of these patients would benefit from a period of time in compression bandaging. So why do patients actually suffer from high volumes of exudate? Well, I think the first thing that we have to discuss is really what is exudate. So exudate is a naturally produced fluid from any wound. When the skin is disrupted, the cells like to bathe in the nutrients of that wound fluid. Many of us think that exudate instantly is bad. Actually, exudate is good. It's a normal body's response to that inflammation. It's a normal cellular response in terms of that required initial inflammation of that wound healing cascade. Exudate is really essential, and it really needs to be there in all the processes of wound healing, because actually the exudate provides all the nutrients required to the cells for them to be able to metabolize. It helps those cells to migrate where needed. Cells like to skate rather than walk. The exudate helps that smooth surface that's damp that they're able to slide over. And it's a really, really important when we talk about autolysis, debridement of that superficial sloughy tissue. That's all done by that exudate, that increased moisture levels, along with all of those cells that's in there. So exudate is needed. It's there throughout all the 4 stages of wound healing, and a normal level of exudate is good. However, once that exudate starts to increase, it actually can become detrimental in terms of that healing. So why are venous leg ulcers so highly exuding? Well, I think that you've got to remember what venous insufficiency is in terms of how the venous leg ulcer has been caused. It's because there's high pressure within the veins, so therefore there's engorgement of the surrounding tissues. The plasma, the water content of the blood is allowed to leak out into that surrounding tissue. So you've got edema where it shouldn't be. Because venous leg ulcers often impact on the lymphatic take-up of that fluid, the lymphatics aren't allowed to pull off that fluid within that tissue as they need to. Therefore, we've got this cycle of increased venous pressure, decreased lymphatic drainage, and this is a cycle of that chronic edema. Additionally, it's just where they are. Because the leg is on that dependent position at the base of us, we often can get patients suffering from chronic edema and therefore higher volumes of exudate. If you've got a venous leg ulcer, you're much more likely to be less active. And remember that venous returns predominantly by the calf and the foot muscle pumping that blood and fluid back up. All of this leads to that engorgement of the capillary beds, that leaking of those molecules into the surrounding space, meaning that the limb itself is extremely congested. And if you've got a hole in the bucket, guess what? The exudate goes from inside the leg, leaking out of the wound, resulting in high volumes of exudate. And when we have high volumes of exudate, we'll always get an increased amount of bacteria, a risk of infection, and there'll always be a presence of biofilm. So the only really way to get these patients to reduce their exudate level is to think about that underlying cause and make sure that we've got that effective level of compression to combat that venous insufficiency and that poor lymphatic take-up. So exudate becomes detrimental because it encourages that bacterial growth. It's a lovely moist environment for bacteria to grow. When the exudate starts to increase, the amount of MMPs, the inflammatory mediators, start to increase, and therefore the wound itself becomes a bit of a toxic soup. That fluid can leak onto that peri-wound skin and cause that maceration. All of this impacts on that very fine balance of that healing that we need. And therefore we get stuck in this chronic cycle of high volumes of exudate, wet legs, and we're not able to move that patient on. And this all results in delayed wound healing. I think we see patients like this all the time, but I just want you to stop and reflect for a minute. Stop and think about if that was your leg right now. Imagine how sore that would be with that exudate dripping onto that sore skin. How dirty would you feel with a wet wound underneath that's smelling a little bit? How dirty would you feel if you're going to go to bed tonight in your cream sheets with a saturated bandage? We really need to stop thinking that this is normal. High volumes of exudate is not normal. It's often because we haven't got the therapy correct. We can't be cutting off bandages and simply saying, ooh, that's wet. We need to be thinking, why is that wet? What can I do actually to help that patient move forward? And the one thing that you can do is make sure that you are choosing the dressing with the right amount of absorbency. We need a dressing that's able to maintain that moist wound environment, but actually pull that fluid away from that venous leg ulcer, retaining that fluid within that, like a lock-away core, if you like, protecting that surrounding lid from that maceration. But it's really important that the dressings that we use are conformable, especially if we're using them around the back of the malleolus. Obviously, in today's NHS, it has to be cost effective, but I would really argue it's not the cost of the dressing that we should be interested in. It's actually, if we can reduce the number of dressing changes, it instantly becomes cost effective. We need to be preventing that strike through. It's not appropriate for a patient to be in a wet dressing at all. We need these to be safe to be used under compression, and the majority of superabsorbents out there are safe to be used. But some of them have got different backings, if you like, so make sure the one that you're choosing doesn't adhere either to the wound or the surrounding skin. So we've touched on exudate and why that's really important, but actually we can't talk about exudate without really talking about edema. Because if you've got swollen legs, there's more fluid there to come through that wound. The word chronic edema is just an umbrella term. Don't worry about using it. If the swelling's been there for more than 3 months, it's chronic edema. And you can use that term chronic edema regardless whether it's because it's a venous insufficiency, a lymphatic. You just need to be thinking about this patient has got chronic edema, and it's a symptom rather than the diagnosis of the underlying cause. But what are you going to do about this chronic edema here and now? Because actually, you'll have all seen this in your clinical practice. I like to call it the edema cascade. It initially starts off to be soft and pitting like you see in that first patient. Over time, you can get chronic skin changes, the dry scabbing, the blistering that can come. The skin can become fibrotic so much it feels like wood really rather than any malleable skin. You can get eczema, hyperkeratosis, the thick skin plaques, lipodermatosclerosis, that woodening effect, and eventually it causes that chronic inflammation and that skin breakdown. Imagine if you had to manage that patient on that far right picture with that very misshapen leg. How difficult will that be for you to manage, and how much difference are you going to be able to make? You're going to be able to make some, but you'll never get that leg back to normality. Imagine though, if you got that patient right at the beginning of that cascade, when the edema was relatively soft and new. If you look at that first patient picture, all of that edema is fully reducible. You can get that limb volume back to normal, and you can maintain it in good compression hosiery. So if you're seeing patients with edema, please think about treating them early as possible in their edema cascade. We've talked about the impacts of this uncontrolled exudate and the uncontrolled edema. It's massive. It's massive because it impacts on the healing time. If you've got a wet leg or a large limb, it's going to impact on that patient's ability to heal. We've talked about the impact to the patient themselves, but actually there's a huge impact to you as the healthcare professional. We need to be thinking about how can we make these patients on a healing trajectory as soon as possible to reduce the impact on the wider NHS and to reduce the impact of you as that clinician. So the one thing I want you to remember from today is escalating a patient is improvement. Don't think of escalating a patient as a failure of your care. If you are not able to treat that patient, if you don't understand the need, if you feel scared, please ask for senior advice. Escalation is the mark of really good care. But in other things that you can do in terms of escalating that patient towards healing is just think about your wound bed preparation. It's really important for the compression as number one, the management of the exudate is number two, but the other thing that I'd like you just to consider is actually how do you prepare that wound bed for healing? We talk about debridement. Remember what debridement is. Debridement is the physical removal of that barrier towards healing. It reduces the bioburden, but it also creates an acute response within that wound. Therefore, you're sort of pushing that patient through that healing cascade. When we talk about debridement, I'm talking about mechanical debridement, not debridement with a dressing. This before and after is simply 5 minutes with a debridement pad. This is what we need to be doing for every patient at each and every visit in terms of preparing that wound bed for healing. When you want to think about how you select the most appropriate method of debridement for your patients, it has to be a mechanical debridement. We've got to be cleansing that surrounding skin and that wound, but then agitating and debriding that wound bed. We know this because we need to disrupt that biofilm. 80% of venous leg ulcers out there have a biofilm, and we need to disrupt that biofilm if we can. We know that there is evidence to say that the more frequent the debridement, the shorter the healing times. So what I want you to do is to start cleaning wounds again. We seem to have forgotten about cleaning wounds. I want you to clean it like you mean it. I want you to use the appropriate cleansing solution that's available to you on your formulary. I want the goal to be to get rid of that unwanted material, to wake up that wound. If you see that top picture with that sloughy layer, all of those wound cells underneath it, it's like a 16-year-old being under their duvet at 11 o'clock on a Sunday morning. They're not going anywhere. What you need to do is to be that aggressive cleanser, come along with your debridement pad, rip off that duvet, remove that sloughy tissue, wake up those cells and tell them it's time to start healing. It's time to get out of your bed, you teenage boy. Remember that we need that pinpoint bleeding. We used to think of wounds as flower gardens. Be careful, you'll cause trauma gently as you go. We know the science has changed dramatically. A wound bed is now like a war zone of bacteria. We need to clean it like we mean it. We need to wake up those cells. It's not about just putting on dressings to encourage autolytic debridement. That alone is not sufficient. We need to be cleansing. And whatever you do, don't forget your emollients post-cleansing to keep that skin healthy and hydrated. So what we need to remember really is that actually wound bed preparation is important, but the key take-homes for all of this to reduce exudate, to reduce the compression, to reduce the edema, compression is the key. It is the fundamental aspect of the management of a patient with a venous leg ulcer. This is the one thing that you can do that's going to make the biggest of difference. Compression is fundamental to manage that underlying pathophysiology, the reason why the wound is there in the first place. It reduces that venous hypertension. It improves that venous return. It actually squeezes some of that fluid back into the capillary bed and back into that lymphatics, helping it to pick back up again. Therefore, it treats that underlying cause. It reduces that limb congestion, and it reduces the inflammatory mediators inside the leg. All of that allows the wound to move out of that inflammatory state, moving into that healing cascade. There's many compression systems available to you. We've talked about some of them. The three main in use in today's NHS is the compression kits. Remember, these are 40 milligrams of mercury kits. It's not the same as a class 1 or a class 2 stocking. We need to be choosing hosiery kits. It's compression wrap systems or compression bandaging. And this little grid chart tells you where it's appropriate to use compression kits in terms of if you've got a normal leg shape, low to moderate exudate, where the exudate is controlled within the dressing, and ideal for a patient who's self-caring. You can use compression wrap systems if you've got a normal leg shape, low to moderate volumes of exudate, great for patients who are self-caring, especially the obese patient group, and they can be used in some limb distortion. But if you've got significant limb distortion in association with high volumes of exudate, your patient requires a period of bandaging before thinking of stepping them down to those hosiery kits or to those compression wrap systems. And just there is a bit of difference really between the compression bandage systems that's out there. You'll have heard the terms elastic versus inelastic systems. So I like to think about this like an old-fashioned panty girdle versus Spanx. So your inelastic systems provide that stiff support like that old-fashioned panty girdle. It provides a really high working and resting pressure throughout that massaging effect. Therefore, it can be used for patients with edema and without edema. There is some evidence that inelastic systems are better at lymphatic drainage than inelastic systems are better in lymphatic drainage than elastic systems. Elastic systems are like your Spanx. They're a more cylinder type of compression, if you like. And they can allow the limb to expand a little bit underneath it. And it provides a more constant pressure with little change, whether the patient is walking or resting. And actually, we know that that's not the best therapy for picking up edema. They're not recommended. They are recommended for patients with no edema, but if you've got some edema, you are better using an inelastic system. So it's about thinking about that difference between that working and resting pressure. I like to think about it like throwing a ball against a wall of a squash court. Within elastic systems, you're getting both the work when you throw the ball and a rest when the ball is out of your hand. All of this helps to actually contract the muscles to express that fluid out of the venous system. And when it's rested, it's allowing those lymphatics to be able to pick up some of that fluid and the veins to re-engorge, so therefore you can push it out again. And the greater the change between the working and the resting pressure, the greater the venous return and the greater the lymphatic return. There used to be a myth out there that inelastic systems were not suitable for immobile patients because we thought that that rebound effect actually only occurs if patients were walking. There's no real truth to that. Inelastic bandages can be used both on mobile and immobile patients. The slightest little wriggle of toes, movement of a leg, causes those fluctuations of those compressions. It causes that rebound against that wall, if you like, and therefore helps to improve lymphatic return. There's some evidence going back to 2014. It's a little bit old now, but you can see on this graph actually what the fluctuations can be achieved. Okay, if you're able to do a whole ankle flexion, you get great movement between that resting and working pressure. But look what happens simply by toe curls or even just sitting up in bed. You still get that same rebound. They are appropriate to be used on immobile patients. This session today is sponsored by Eleanor. Their inelastic bandage is called Actico. I'm quite happy to promote Actico because actually it's the bandages that we use in clinic each and every day. I like Actico because actually it really helps in terms of mimicking those working and active pressures. It really helps to be effective both on the venous hypertension side, but also the edema side. And there is a great thing about Actico. If you've got a challenge from a patient to say that your bandage feels tight or too firm, Actico is a great bandage. It has a slight increased comfort level, but actually if your patient's finding it slightly too tight, the best thing about Actico is simply get them to elevate their leg. Because of how the cylinder compression works, the discomfort will slightly reduce, but the venous pressures, the reduction of the edema will still continue. And there's nothing better than compression therapy and elevation in healing a patient with venous leg ulceration. Additionally, the Actico bandage is applied at full stretch, so there's no fear about am I over compressing it? Is that a rugby ball or is it a tennis ball? It gives you that peace of mind because you've got that constant stretch. Therefore, you know you are being accurate applying this. When you apply a good Actico bandage, it should feel very firm. It should feel like that panty girdle, if you like, holding that leg in place. Eleanor have provided a number of solutions throughout the whole of your patient journey. I think what's really important is, unfortunately, it's like a game of snakes and ladders sometimes. Your patient can come up this diagram, but easily come back down again. To me, the centre of this is that we need to empower our patients of their ability to self-care, to talk to them about why they have venous disease. It's often due to reduced mobility, reduced exercise, and obesity. We need to be talking to our patients about how they can self-care and improve their overall long-term benefits. But it's also linking to what's the evidence-based treatment for the patient wherever they are. What's the evidence-based treatment for managing a patient with an active leg ulcer? It's strong compression. What is that early prevention? What could it look like? Well, it's compression early on in that edema cycle. It's about getting that patient into that early 20 milligrams of mercury pressure at the assessment of those red flags. And it's about really focusing on that prevention of recurrence. If we work with our patients through this pathway, we will be more successful at preventing that recurrence. We will if we can find a compression system that's therapeutic for our patients, that they are happy to wear. We will find that our recurrence rates comes down. But I think it's really important that we work with patients. We need to be in dialogue with patients about what is their expectation. There should be an expectation that a venous leg ulcer heals. It should heal within 12 weeks. If not, why isn't it healing? But it's actually informing your patient, don't look for wound healing as the first sign of improvement. The first thing that happens with a patient with a venous leg ulcer once they go into compression is the first thing is that you'll find you'll have a reduction of limb volume. The next thing that happens is the exudate starts to reduce, and then finally the wound starts to reduce in size. And it's about informing your patients to look out to these early signs of progression towards healing. Once the exudate volumes and edema has reduced, we need to be talking to our patients about these self-supported solutions, asking to them what garments would they consider, compression hosiery or compression wrap systems. Many of our patients are going to be in these systems on a lifelong basis. Working with them whilst they've still got their leg ulcer to find a system that they are happy to use independently will help to reduce our risk of long-term recurrence. We need to be thinking that actually the patient really needs to understand the expectations. And in other words, if a patient isn't willing to go into strong compression therapy, we need to really think about changing their expectations. The expectation is they will heal if they're in strong compression. The alternative exists. Without compression, these wounds are probably not going to get any better. It does help talking frankly to your patients in terms of getting them to accept the need for change, for them to understand the requirement of compression, and for them to be welcoming of that compression therapy. Eleanor's also got more great resources that's available to your patients to help them, to empower them to manage their own health and their own leg health. This Club Squeezed In is a fantastic campaign. It provides information about nutrition, movement, exercise, hydration, and it's all backed by the amazing Johnny Vegas. Have a look at all of those resources, signpost to your patients to this fantastic resource. So in summary, when you're managing a patient with a lower limb wound, just make sure you're following evidence-based practice. A great way to do that is simply use the Atkin and Tickle pathway. It spells it out in one sheet of A4 paper. We must try to get our patients into those self-care solutions at all possible first time. However, if there's high volumes of exudate and high volumes of edema, that patient requires a degree of bandaging before we can step into those self-care solutions. We need to be debriding. We need to be shaking up that wound. We need to be using the appropriate dressing with the right amount of absorbency. But we need to be pushing our patients to progress towards that healing, reducing that congestion in the leg, reducing that chronic inflammation. And the only way to do this is full therapeutic strong compression. Engage with your patient to ensure that they are progressing through this pathway. If healing is not occurring, question why. Non-healing is not normal. It needs to be challenged. So just a few takeaway questions before we'll go into the live question and answer session. I simply want you to think and reflect tonight. Are you healing patients with a venous leg ulcer, or are you simply managing the symptoms? We need to be aiming for healing. If your patient's not healing, why not? Are all your patients who are suitable in strong compression therapy? If not, why not? What can you do tomorrow to increase that level of compression, to ensure that patient has the appropriate dose of compression to treat their underlying disease? And do your patients truly understand the reason for compression? The need to. It's going to be their lifelong compression journey. We need to get patients to truly understand their underlying disease, the need for compression, and the need for them to take responsibility and ownership in their lifelong compression journey. So I hope you found that informative. I'll hand back to Alec and see if we've got any questions. Thank you.
Hi, Leanne. Thank you very much. We'll see if we've got any questions. We've got dozens and dozens of them, and they're still coming. So that's a good time to finish, because it hopefully means we can get through quite a few of them. Yeah, so thank you very much for that presentation. Just to the people watching at home, we do still have time to take questions. We've got about 15 minutes. If we don't get through them all tonight, we, as usual, what we'll do is we'll put them all into a document. We'll put them onto a PDF, and you'll be able to download those alongside a copy of the actual video within a week or so. Just to remind you, this is the second part of a three-part series. We'll be back for the third event. Let me just double check the date so that you can stick it all into your diaries. Part 3 is going to be on the 11th of October, and that's with Leanne again, and that's embracing supported self-care. And then what we'll do is on our website, we'll put all 3 of them back to back so that you can basically have a look at all of the questions that come in. And what'll be really interesting for us, Leanne, is to see what what sort of questions have come in between 1, 2, and 3 for all the people who have actually followed all 3 parts of this series. But for now, I'm going to go straight onto the questions. As I said, there's quite a few of them that have come in. Question number 1 is, we struggle with patients who are healed, and when we try to move them into hosiery kits and wraps. Okay, we struggle with patients who are healed when we try to move them into hosiery kits and wraps. Any suggestions or solutions for this?
I think the problem comes with this is how the NHS is currently set up. I do hope that the movement towards, health boards, if you like, it feels like going back to the 80s sometimes. I think the movement of bringing social care and NHS care together may help this. I think the difficulty comes is that you get nursing support whilst you're healing. Once you're healed, you get no nursing support and off you go on your own. Therefore, if you use a compression bandage right to the point of healing, you measure them and supply them with a hosiery kit, let's say, they've got no ongoing support. So to me, the way to do it is actually get them into compression wraps or compression hosiery earlier on in that journey, while they've still got a wound, while they're still needing nurse support. Therefore, you can look and help and educate them. Some compression digs in around the crease of the ankle. Well, therefore, you might need a different type of knit. You might need a flat knit garment, or you might need a made-to-measure garment. Some of them roll down. Again, you might need a different silicone top to keep it up. Some patients simply cannot apply because they haven't got the dexterity. So you might need to think about using a compression wrap device instead of compression hosiery. So I think it's actually moving your patients into that more compression wrap or compression hosiery whilst they've still got a wound, whilst they've still got nurse support. So you can firefight with them to get them into something that they're gonna maintain in when they have healed and when you need to discharge them off your books. I do hate the fact that we do discharge patients with venous leg ulcers. I do think they should be with us forever, but unfortunately there is that very clear line between NHS care and social care at this moment in time. I hope that line will disappear in time.
Okay, brilliant, thank you. I hope that makes sense. Question number 2 is, if anything less than 40 milligrams of mercury pressure compression is not effective, why does the National Wound Care Strategy Programme state to use 20 mils for immediate care? Okay,
so 20 mils in the National Wound Care Strategy is just first aid. It's quite clear. You should only be using 20 millimeters of mercury up to maximum of 14 days. We put that in because we do appreciate in some services there are a delay in getting that arterial assessment, that ABPI. So I am a great believer in some compressions better than none, however, only for a very limited time period. It's really important that 20 is only used for a maximum of 14 days, and at 14 days maximum, we have that full holistic assessment. If that patient has good arterial supply and is diagnosed with a venous leg ulcer, they need to be in 40 milligrams of mercury pressure. And the National Wound Care Strategy says that very clearly: immediate and necessary first aid, therapeutic management.
And to be clear, you're part of that strategy, right? So you're part of the decision-making process to say that we should do 20 initially.
I was joint chair along with Brenda King of the lower limb group who wrote the recommendations along with Una. We're all now stakeholders in that. It's being led by Una Radley and a fantastic group of clinicians, and she's pushing this throughout the whole of the UK. So I'm still involved, but only as a stakeholder. But what I would say is I'm a great ambassador for the National Wound Care Strategy Programme. That is what we should be following. It is the best evidence base. It is the best way to treat patients with lower limb disease.
Brilliant. So somebody else, next question, number 3. The pathway makes sense, but what advice do you have to help us implement it? Due to high staff turnover, there's variation in the training our nurses are receiving, so people are doing things in different ways.
I completely get that, but in a way, I think that we have to call out for a change, because if not, we're just going to be sat here saying the same thing in a year, in 5 years, in 10 years, in 20 years when I retire. I think the one thing that you can all do is start to implement it tomorrow. The pathway isn't brand specific. The pathway is just a decision-making algorithm of what you should do. You can use that, whoever you are, even if it's not endorsed by your organisation, you can use that because it's based on the National Wound Care Strategy profiles. So So you can use that as your aid memoir to make a difference to your patients that you are seeing. You will improve your healing rates by using evidence-based pathways. But then I ask you, how do you influence others? Because actually all of you out there are able to influence your peers. And the best way to do that is just talk about your fantastic healing rates. Have a diary. Say to people, do you know my healing rates for patients with venous leg ulcers is 90% at 12 weeks? You'll soon catch the eye of people within your team. If you are that service leader, I challenge you, why aren't you implementing the National Wound Care Strategy standards? It's our requirements as service leaders to ensure the policy is in line with the national recommendations.
Okay, brilliant. Next question. When should we use inelastic? You were just talking about this. When should we use inelastic or elastic bandages?
So inelastic can be used for any patient across anything. They can be used with edema, without edema. They can be used in immobile or immobile patients. For me, their sweet spot of inelastic systems is edema reduction. It's fantastic at it. For elastic systems, pure elastic systems really only affect the venous hypertension, not so much the lymphatic. You need to have a system with inelastic properties to truly impact on edema.
Okay, so next question. In practice, we're advised not to apply any compression without Doppler. Despite the National Wound Care Strategy's immediate care guidance, how can we overcome this and advise our peers and leaders about this best practice?
I think that really needs to be challenged head on. I find that who is that leader of that service and why do they think they are better than the National Wound Care Strategy Programme? Those clinical recommendations is not me saying this, it's not Una saying this, it was a body of around 50 clinicians that implemented into that document. That is the consensus of the best practice. We are looking at getting that in a nice guidance. If you are getting resistance, you really need to challenge it. Why on earth not? And Una and her team would be more than happy to come to talk to your service leaders about the importance of implementing this. I appreciate it's a challenge, but we've been crying out for years upon years for venous leg ulcers for national guidance. We've got it. At least we need to start reading it and implementing it. We can't start now slating it. It needs to be implemented. 20 milligrams of mercury is thought to be safe without a problem. You need to be Doppler within 14 days. If not, you're elongating patient suffering. We need to be using strong therapeutic compression as soon as we can.
Okay, brilliant. Next one, there's a lot of reduced compression used for venous leg ulcers in my area because of historical decisions that the patients won't tolerate more, when actually they are suitable for full compression. Is there any way to address this with existing patients who are used to reduced compression?
Yeah, just talk to them about, would you take one paracetamol for a headache? That's the same thing. They're taking half the dose of what's required. Those patients will probably be long-standing. Well, they're long-standing because they're in reduced compression. You need to talk to them about the therapeutic dose that's needed. The reason why your leg is still like it is we haven't got the dose right. We need to be increasing the dose. We also need to be tackling it. Those patients have been failed. They've been harmed. Whoever decided to put that compression on reduced nature at the very beginning, when the patients were suitable for strong compression, they've harmed that patient. We need to be educating and tackling those to be able to change the culture. It's much more difficult if a patient's in reduced compression to get them up to strong compression. It's a lot easier to get them in strong compression from day one. I appreciate when you put a patient in strong compression, the first 14 days, they may have an increase of pain. They may find it uncomfortable. They may require more analgesia. Within 14 days, the venous pressures go down, the inflammatory mediators go down, the limb congestion starts to reduce, the exudate starts to reduce, the wound will start to heal. So it's about asking your patients to give me 2 weeks and let me show you what the right dose can do. But keep challenging it. Whoever that was, you are the solution to this problem. Keep pecking away. That's what we need.
Yeah, I guess that question's been asked quite a few times even in events that me and you have done together in many different ways, hasn't it? It's the same sort of thing. How do you get whether it's talking about non-compliance or just patients who just don't want to tolerate it. How do you get them to tolerate it? But I think that the paracetamol headache analogy is a good one. It's one I'll remember. Okay, so another question: at what point do we define exudate as controlled and able to be managed in a self-care solution?
Easy. It's not leaking out of the dressing, so it doesn't matter. A lot of the dressings look wet from the top, but they're not. So long as it's not leaked through, there's no staining within it, the exudate is controlled within the dressing. And bordered dressings are really useful sometimes to keep the exudate in play. Super absorbent dressings are fantastic because they'll wick it straight through. So the exudate just needs to be within the dressing. So let's say that if a patient's got a blue line tubifast over the top, there's nothing on it, it's clean. You take that wool bandage off, if you're on compression bandage, there's no strike through onto that compression, onto that wool layer. It's about just being controlled within that dressing.
Okay. Well, I think that. Sorry, go on. I was just looking at another question. I think there's another question here that sort of links onto it, which is are there instances when you could use self-care garments for patients with high exudate or edema?
Yeah, there are. I don't think so much with edema. Hang on. Okay, compression hosiery kits with large volumes of edema, no, because it's based on a normal looking leg. You'll never get the right profiles. Compression wrap systems for high volumes of edema and limb distortion, yeah, you can. And you know what? If that patient's got really high volumes of exudate that's requiring twice a daily dressing changes, you can think about using a compression wrap system. But I would say that patient needs really expert care. You really need to have a clinician who knows what they're doing with that. I don't want everybody in that. At this moment in time, the evidence for short stretch bandage is so much superior than compression wrap systems for edema and exudate and leg ulcer healing. There's a study called Venus 6 going on. We might find out if compression wraps are as good as, but at this moment, I think that we should be trying to get patients into evidence-based solutions. That's compression bandaging. If though your patient's saying, do you know what, I work 12-hour shifts, there is no way I can see a district nurse before going to work and after going to work. You need to enable me to do my own dressing changes. Super absorbent dressings and compression wraps have a place in time for that patient. But it really needs to be a clinician that's balancing that individual circumstances, the risk of slightly lesser compression versus the risk of arterial disease and the need for strong compression. It's a bit of a fine balance.
Okay.
And this is why I said, if you are relatively new at this and you don't feel comfortable at that level of decision, escalate, ask somebody for help. Like I said, escalation is a marker of really good care. Just seeing a patient and thinking, I don't know what I'm doing here. Is this the right thing? Is that the wrong thing? That's what we need to be challenging. You need to have the confidence to be able to manage these patients, knowing that you know how to manage them.
Yeah, okay. Listen, Leanne, there are tons of questions left. I've just been scrolling through a couple of them, and there's just one that really stands out to me, but I'm going to give you a one-word answer to this. I think I know what it's going to be. So this is, as nurses, there can be serious consequences when a pressure ulcer deteriorates on our watch. Do you think venous leg ulcers should be treated as seriously, i.e. serious consequences?
I can't give you a one-word answer. The answer to that is yes. And do you know what's even worse with this? Let me just back it up with.
We got 5 seconds.
Yeah. We know how to heal a venous leg ulcer. It's called compression therapy. We do not know how to heal a pressure ulcer. We don't actually know how to stop a pressure ulcer properly. We have high evidence-based care of how to heal a patient with a venous leg ulcer. To me, it's even more important. If patients aren't healed at 12 weeks, there should be day text. I think it's harm. I think we should be reporting it. I think we should be challenging it.
Well, pressure ulcers, we do. I mean, I can't even think off the top of my head how many sessions we've done on, pressure damage versus any other type of wound. So that's a whole different story. We've got lots of that over on our urology and continence care today site in particular. So do go and watch any of that. The nurse that sent in that question. I'm aware that we haven't got through all of the questions, but as I said earlier, we will put them all to Leanne and to Eleanor, and we'll come back to you with the document that we'll put next to the video. Leanne has mentioned some wonderful campaigns, Squeezing in particular with Johnny Wilkinson. There might be a website
Johnny
on your screen
Vegas.
at the moment. Johnny Wilkinson, I'm saying that. That's me as a sports fan. Johnny Vegas, I do apologise. If you don't know the website, I've been using this all weekend as I've been walking around Pride in the heat. This is the Squeeze In Lip Care. So this is squeezein.life. Go and visit that. We'll make sure that we put that website onto the page as well. There's also a Facebook page, or a Facebook group, which we run in association with L&R, which is the Venous Leg Ulcer Clinical Leadership Program group. If you're not already a member of that, hop in and join it, because we put lots of stuff throughout the week into that group as well. So it's a really interesting group if you're interested in the subjects that we've been talking about tonight, and as part of this 3-part series. Leanne, you've been absolutely fantastic as always. It just always seems like it's such a natural thing for you to be sat there doing these presentations, whereas I think people like me, we struggle with it a bit. So thank you very much. Thank you to the whole team at L&R for your work this evening. Thank you to everybody watching, and thank you to my team at Mole, and thank you to my team at Wound Care People. We'll be back, as I said, next month for part 3. Please do share this with your colleagues. A link for your certificate should be available to download now. Have a wonderful evening, and we look forward to catching up with you again in the next couple of weeks. Good night.